So these are three different products. They're not exactly the same. What do we know about those differences?
Well, one thing is the product themselves, the co-stimulatory domains in the product. The Axicell is a CD28 product, and the other two are 4-1BB co-stimulatory domains. And there's some biologic differences between the two. The CD28, it looks like, results in perhaps a little bit more rapid expansion of the CARs, whereas the 4-1BB co-stimulatory domain may be a little bit slower, but maybe with more persistence. We don't know that. There's also some differences in the lysocaptogene marilucil based on data from your institution, David, that suggested that in the laboratory an equal amount, a 1-to-1 ratio of CD4 and CD8 cells might be preferable, at least in animal models, I think. And so when we're using the Transcend, the Juno product, the Lysocell, it's a 1-to-1 ratio, and it's a 4-1BB co-stimulatory domain.
What do we know about these patient populations in these two trials?
Well, I think beyond the relapse refractory large cell population aspect of it, it's really what do the patients are allowed to do. For instance, on the ZUMA-1 trial, no bridging therapy beyond steroids was used versus the other constructs are allowing bridging therapy. So really you have to ask yourself, I think, can I bridge this person, or do I need bridging therapy if I'm using a commercial product or if it's on a trial? And I think that's really an individual discussion. The majority of the people are getting bridging therapy. Even in the real-world experience, there appears to be more bridging therapy with the use of Axicell. I think as more data emerges with regards to debulking and potentially outcomes.
I think also what I would say to that is that the question of bridging therapy or not brings up another point that we haven't talked about yet, that we have to recognize as we're trying to interpret these clinical trials, and that is this type of therapy, just by its nature, by the fact that there are limited slots on clinical trials, by the fact that it takes anywhere from 2 to 3 weeks to manufacture the product, by the fact that bridging therapy is not allowed in some, is an automatic sort of selection bias that we have to be aware of. And I think there's a selection bias for clinical trials in general to include more favorable patients, but there's a special selection bias in these studies because it takes a while and these people are sick. And those patients that can eventually make it through to get the CAR might be a better group of patients. So we have to be aware that our data might be skewed to the more favorable. And I think as we begin looking at the real-world experience, and there are a number of abstracts at this meeting that address that, we may see a slight drop-off in our results, and we have to be aware of that.
Let me throw out a question, though. You make it sound like some of these products are better than other products based on these 3 studies. Is that really true?
I think we can't say that yet. Yeah. No, I don't think there aren't data. In fact, even if we have final data on all 3, cross-trial comparisons are very difficult to do. The only way we'll know the answer to that, I'm not sure this will be done, but the only way we'll know that is to have randomized studies.
Exactly. I mean, a key point to emphasize, the patients aren't exactly the same. They're different. In each trial, the way the product was handled, the intervals between infusion, there are a lot of factors that really weigh into that. So we know that they respond. We have some evidence of long-term response, but we really don't know comparatively what's best.
Yeah, and I think you could even drill down to the lymphodepletion chemotherapy, which all 3 regimens were different. So, Cy-Flu or cytoxin fludarabine was an option, but in the Julia trial, I think that you didn't have to get necessarily any lymphodepleting chemotherapy, and bendamustine could potentially have been an option.
And many studies have shown the right lymphodepleting chemotherapy makes a big, big difference. So that's an important thing.
But it's interesting the differences in the doses too. You got to pay attention with the construct also.
The other thing with ZUMA-1, they allowed only refractory patients or patients who had relapsed within 1 year post autotransplant. The other 2 trials used relapse refractory and also autotransplant. So that was a little bit of a different thing which Zuma 1.
I think in the pivotal cohort, though, within the Lysolar Transcend trial,
Majority of
you know, that was a very interesting trial to watch it navigate through the dosing cohorts to get to the pivotal cohort, which more became in line with the axi-cell cohort.
One question that comes up about lymphodepleting therapy, I mean, it is just to clarify this a little bit, I think it's clear to us, but I want to make sure that everyone understands this, is that it's designed as a lymphodepletion. It's designed as an immunologic treatment to allow expansion of the CARs. And I heard a question at the ASH meeting yesterday as to whether the lymphodepleting therapy might have been caused the remission, or might have been actually the reason the patient had remission. And I think you want to stress that these patients have had multiple treatments. They're refractory to this kind of treatment, and it's very, very unlikely that any of the response is related to the cytoxin fludarabine.
You can argue also a lot of these patients haven't seen fludarabine, but we're going to get to toxicity, but potentially some of the toxicities that we may see after CAR T-cell may be related to some of the lymphodepleting chemotherapy.
I think these are excellent points, and I think that the three trials have all shown tremendous activity with complete remission rates in as high as above 50%, and the durable responses appearing to be in that 30 to 50% range. And there are a lot of differences. But there are also differences in safety. What do we know about these three different products?
Well, I think that what we're seeing is we're looking at the two issues in terms of safety are cytokine release syndrome and neurologic toxicity. And one of the problems in interpreting the data is that not all the trials have used the same criteria to define those problems. And I think in your institution you're beginning to harmonize that and to look at that. And I think we need to do that. It appears that the cytokine release syndrome seems a little bit lower with the 4-1BB product, but that might be a consequence of the way we're measuring cytokine release syndrome. Neurologic toxicity is in the range of about 30 to 35%, with most of the neurologic toxicities being grade 1 or 2, not grade 3 or 4. I would add that even grade 1 and 2 neurologic toxicity for a patient is significant. Maybe for a clinical trialist it's not, but for patients, loss of word finding, confusion is a significant event.
It's an event for their caregiver, too,
and for their caregiver.
going through
You know,
with
they
them.
certainly need to be aware
Yes.
that this is going to happen. And the big question is if these are long-term toxicities or they contribute to long-term toxicities. And so far we haven't seen that in low-grade neurotoxicities, but we need to watch.
Correct.
Yeah, I mean, I think the lesson is so far, it looks like most people can recover from these toxicities, but they can be severe. And patients have a fairly high chance of ending up in the ICU and with almost any of the products if they have severe cytokine release syndrome or neurologic toxicity. So I think this will impact the ability to give these products in the outpatient setting. We certainly have experience with the 4-1BB constructs using them as an outpatient setting, whereas the CD28 axicaptogene pretty much requires hospitalization for at least 7 days, and I think the median was around 16 days in the clinical trials.